which now has given birth to the Social Health Authority. So if you look at the structure and if you compare with what we had at the NHIF, the National Hospital Insurance Fund, is now you have 3 funds. So the first thing you realize is, one, you had to be a member to get any benefit, which was NHIF. Mm-hmm. When you look at now SHA, Social Health Authority, there are 2 funds that you benefit, even if you are not a paid-up member, but you are just registered. And that is the primary healthcare fund and the emergency.
So it is essentially free?
It's because that's government money. Okay. It's taxpayers' money. Mm-hmm. So you don't need to contribute to benefit from the primary healthcare. And that gives you your outpatient services for your general ailment. Now, when you need moving forward, you need to be admitted, you need surgery, you need this, then you need to have contributed 2.75%, or you have been paid for by whoever is paying for you, whether it's the county or national government, you are an indigent, or you are paying the minimum of 300 shilling, then you benefit from the Social Health Insurance Fund. So if you look at the way the SHA, Social Health Authority, have been structured, from the governance all the way to the dispute resolution, you will see there's a departure from what we have. Looking at the board, you will realize now it has a wider representation, including the Director General of Health, which previously did not sit at the NHIF. You have the Informal Workers Association. You have COTU representative. You have providers, private sector. You have CECs for health from counties. Mm-hmm. You have the professionals through KMA. Then when you come to how it does its work in terms of empaneling facilities, that is allowing a facility to provide services. Previously, it was done at NHIF. It was the NHIF officers who were doing that work. Yep. And that created some conflict, because I'm the one who is empaneling you. Mm-hmm. I say no, and then you have to talk to me nicely, then I put you in the panel. But for now, what we are saying is the empaneling is done by another government agency, which is the Kenya Medical Practitioners and Dentist Council. Yeah. Because they are the ones who license you, they are the ones who regulate you. So they are the ones who are able to say, Abdi's facility, XYZ, can provide this and this and these services, and this is the license that we have given for these services. So as SHA, we now tell you, this is the contract mm-hmm. that we have, this is the benefit, and this is the amount that we are paying. Mm-hmm. So you come in and you look at and you say, I am comfortable with these prices and I want to be contracted, and you take it.
For example, dialysis at 12,000 shillings, as an example.
Yes.
We're going to say that if you're going to come onto the panel, you're going to then be able to deliver dialysis at 12,000 shillings, knowing that folks need it 3 times a week, for example.
Yes.
Okay. And you accept to take it at that price.
Yes.
Okay.
So what happens is and that is something that's published and gazetted. Okay. So it's not something that is amorphous, that you are not aware. It's something that you can clearly download if you want and go through and see, this is what I am being paid for, and this is the amount that Social Health Authority is paying.
Is going to pay. So sorry, I have to come back, because remember just a year ago, we had this crazy thing where there were particular service providers and a dialysis was a big one. That's why I remember it, that there was an amount, okay, are we going to pay 18,000 shillings? Are we going to pay 9,000 shillings? It's not possible for us as private entities to offer this at this amount, because that is what now we will receive or not. So what you're saying is that no matter the entity, before any of this comes on board, you will have agreed that if it's dialysis, if it is chemotherapy, if it is this or that or the other thing, at whatever level, any entity is going to have pre-agreed to do that and then offer it, so that the poor folks who are going to come to hospital are not going to be told, sorry, we can't offer it, go back.
So let me explain, because when that problem was there, I was on the other side.
Yes, you were, I remember.
I was a provider representing the providers.
Yes.
So the challenge was, at that time, NHIF was proposing to pay 6,500. But they were also saying you can't co-charge. So what we were telling them is, if you reduce from 9.5 to 6.5, and you say don't co-charge, then what you are doing is it's impossible to provide that service. Which now a facility should be willing to say, I'm not interested. So you look for a facility that can take. But for now, what we are saying is, the other challenge that was happening is a facility requests for a procedure. The contract says 10,000. But someone at the office of NHIF approves 30,000. An extra 20,000, which is not in the contract, which was not a benefit to the individual. So what this now benefit and tariff is doing is, we are all equal, every Kenyan. There is no special scheme, there is no civil servant scheme, there is no retirement scheme, there is no county scheme, we don't have 97 schemes. We have only one scheme. And that one scheme gives equally to everyone. So if you need it, this is what you are entitled to. If you don't need it, then you don't, of course, you will not utilize it. And that should be, it's something that you are able to see even on your phone once the portal is up. And then you can be able to see, this is what I'm entitled to. That's if you have a smartphone and you have logged in and you are able to utilize. You will be able to see, this is what I'm entitled to, this is what I have used, this is the hospital that I have gone. So I was going to, now what is the difference?
Yes.
So these now benefits and tariffs are things that are published and they are gazetted and things that we can all see. What next have we created? Previously, it was at the level of NHIF where these things were being done. And it was being done by the staff alone. Now we have created out of it an entity, a research entity at a university level, a committee, which has patients, providers, Ministry of Health, Social Health Authority representative, the CSOs, so that it's something that is a continuous process. So today you will say this disease is not covered, for example. So CT can petition that committee and say, why don't you add this procedure? Or today, the Social Health Authority says the amount we can pay for is up to a maximum of 10,000.
Okay.
But CT, because knows this disease, the money required is 20 or 30,000. There's more that he pays maybe out of pocket because of the facility that he has chosen. So now he can say, can you increase the rate that you are paying so that I can benefit as well? So that now is outside and not within the Social Health Authority. So we all have a say, and that's a continuous process where we can revise that benefit and tariff every 2 years. That is what we have agreed on. So if you look at what else is different from what is happening. So the other thing that has been put in place is everything that Social Health Authority does is supposed to be done digitally. No paper work from end to end. From your registration to your payment, to your claim, to all your journey is supposed to, even with the providers, is digitally. There is nowhere we will have paperwork. So that also reduces and shows and allows us to see how is the journey. You can easily audit and see where is the issue, and put even the controls within the system, so that you are trying to put in. It's like trying to send through M-Pesa 1,000 shilling and you only have 500. It will tell you no, it can't work because the money you have is not enough. Similarly, you cannot claim a benefit, or a facility cannot claim a benefit which you are not entitled to, and ask. Or a facility cannot say, Ndu is here, we want you to pay 100,000. But the tariff says it's 30,000. So you can't. The system will not allow you to proceed to move on. Finally, which has been a biggest challenge for providers, and if you look at then they will tell you, is because NHIF as it is was doing everything. They were the ones who are empaneling you. They are the ones who are giving you the contract. They are the ones who are deciding what is the benefit, what is the tariff. They are the ones who are deciding on the approvals. They were the ones who are processing your claims, and they were the ones who are paying. And when you have a problem with all this, you still come to me and have a discussion, and I tell you whether we can solve or not. If you are uncomfortable, you can decide to walk away. Now we have...
Okay, for purposes of clarity, we're saying what used to be the case.
Yes.
Okay.
Yes.
In terms of the benefit that SHA will offer now. SHA,
so now what we are saying is we have a dispute resolution mechanism, which is a tribunal at the judiciary, which handles your issues between providers and social health authority, between patients and social health authority, so that you have a mechanism of addressing an arbiter. Of course, as an individual, you will first go to the authority, see whether your disputes can be solved. But if you are uncomfortable with the ruling or the decision that they have made, you have an avenue, and you don't have to go through the normal court process that we have. Okay. And that's why, for us, with this social health authority, what it tries to do is to put everything on the table so that you have clarity on where each and every individual needs to come in and hold accountable the system.
Even when the system is implemented,
yes,
it will still be a pilot. Let me explain what I mean.
Yes.
Because it is new.
Yes, yes.
And what mechanisms have you put in place that will guarantee that even as we chug along, we are always collecting data and seeking to ensure that the problems which will surface, not might, will surface, some of the things that have been planned for and thought of, implementation normally presents something different. That we will be ready for all these eventualities, and we'll be constantly ensuring that this is a work in progress so that we can actually deliver the ideal.
That is the work of the board, and that is what we are working on, to make sure every now and then to improve on what we have. And that's why the benefit and the tariff is not constant. It's not something that is cast in stone, and we are saying, this is what we have given you as a benefit, and it's done.
Okay.
And that's why we have that mechanism of addressing. But at the same time, operationally, the board will be able to handle every issue that arises, including whether there were challenges with providers, including whether there were system issues, including whether there were design issues, including whether there were payment mechanism that had an issue. So this, we are not saying, and that's why I told you at the beginning, we will not start perfect, but we will continue adjusting and changing the all the challenges that we encounter as we go along.
Okay.
Okay, so it's good to know it's not cast in stone. I'll start with a point of clarification here.
Yes.
There's so much controversy around the Linda Mama program.
Yes.
So kindly clarify to us, is it still encompassed under the Social Health Authority? It falls under which specific fund? Will, mothers still continue benefiting as was? And now number two, Still yet another controversial issue, because we've seen means testing and the controversy surrounding it, especially in the education sector, higher education and whatnot. When we come to means testing right now under the Social Health Authority, what happens to contributions perhaps that have been paid in advance by a self-employed person if that means testing determines their rate perhaps is higher or lower than, is it 500 the minimum?
The minimum is 300.
Yeah.
So the minimum is 300. So if you pay, if you have paid in advance, and the means testing says you have paid up to this amount, but this is the extra that you will top up. If it says you have paid and you have overpaid for this next 1 year, then it's carried forward.
Okay.
So no money is lost. Nothing of yours goes to waste because it's part and parcel of your what you have paid for, and you have to benefit as it is. So that's what will happen. The second thing is the means testing that's happening for the health is a little bit different from the way the data is being analyzed. It's not to say that it's 100% perfect. You will have a few issues here and there, and that will be a percentage of 1 or 2% underpaying or overpaying. And we will have an appeals mechanism where you can say, I have been over-prescribed. Coming to the issue of Linda Mama, yes, it will be part and parcel. Every woman who needs the delivery will be paid for. Not only paid for, because Linda Mama was just paying the delivery alone. For this one, it covers the whole family. Now we are moving away from an individual for an event to a family for everything else that they need, including the father, including other children who are not part of this event, including complications that will arise to the mother herself. Because the way it is now, it's the event, which is delivery, complications is separate. Now you need to pay out of pocket or have your other cars or whatever it is. Your other child is sick, they are on their own. Your husband is sick, they are on their own. So now what we are saying is, not only will we cover for that event, which is the delivery, but we will also cover the family as well.
Okay.
That's the idea.
There is also worry in terms of what happens because, you talk about the first level, you're going to go in with your card. With this card, when it's going to come out is another question. The registration, we understand, is ongoing. I don't know if people have been registering, but if you have this one card, you're going to take it from one place. You're going to go into hospital with it. And you've been previously paying your premiums for NHIF. That money carries over, I'm assuming.
Yes.
But you've also said that the 2.75% of your gross net, whatever the case may be, is what is going to cater for emergencies.
Not emergencies. Emergencies is from government.
I'm sorry, it's going to, at the next level, is what's going to cover
It's
for
your
surgeries.
social, yes.
It's what's going to cover for surgeries and those other medical interventions.
Yes.
If you've not started paying the 2.75%, because, we are still waiting for SHA to sort out itself, how will you then get the coverage if that money has not been accounted for?
You will, first of all, you will not walk around with a card.
Okay.
We are moving away from the card. If you have tried and registered, you will realize all it's asking for you is your national ID or any other identification, passport number. If you are a foreigner, your residence number. If you are a refugee, your refugee card number. So you don't need to walk around with a card. Even when you go to the facility, you will just mention your ID number and say, this is my number, and they will be able to upload your information. So the issue of cards does not appear anywhere going forward. So the 2.75%, as you are aware, is for individuals who are formally employed, and individuals who are not formally employed will undergo the means testing, and they will be told what exactly. When you register and you fill in the questionnaire, it tells you this is what you need to pay at the end of your registration. For the 2.75%, that now goes to the employer. The same way now for NHIF, it's your employer who submits that CT, this is his salary, this is the amount we are deducting, and they will submit to SHA. And that will happen end of October.
Okay.
Because usually it happens at the end of the month.
What if I am not employed?
Yes.
And I wish to be
Contribute.
Yes, exactly.
Yeah.
You will register. When you go to the star 147, you will be able to register. You fill in all the questions, star 147. That is the registration number, and that's what we are
Star 147 hash.
Yes, hash.
Okay.
And that's what we wish everyone to register. And all you need to do is fill in your ID number, and it will ask you a few other questions that you will need to fill in. But majority of the things will be pre-filled. Once you give your ID number, that's enough. It will fill in your date of birth, all those things. It will fill in automatically.
Okay.
And then you will proceed to declare employed, self-employed. If you are employed, you will say employed, and then it will not proceed. It will tell you who is your employer. You will fill in. If you are self-employed, then now is where you move into the means testing questions, and you will exit. At the end of it, then it will tell you, once you are done, when the time comes, this is your premium that you need to pay. And one thing that I would like to appeal to Kenyans is to realize the power of people coming together and having this insurance, and understanding that insurance means something that you take in advance for unforeseen thing. You can imagine if today we said you only pay for insurance after you are involved in an accident with your car. There will be no insurance companies that will survive.
Exactly.
So there is no way we can pay for premium only when we fall sick.
Yep.
It's unfair.
It has to be there as a guard, just in case.
And the person who was earlier was talking about pension. Most pensioners use their money for medical. Why? Because it's at that age where you need medical most.
Exactly.
So now imagine when your son says, 2.75, I don't need to pay. Not realizing that his father is paying 300 shilling.
Yeah.
Because he's old now, he has retired, he's in the village. Now the minimum is 300, that's what he's paying. Because you are young, you're paying 2.75, not realizing that this is the pool that we are all drawing from.
Yes.
But he's looking at himself and saying, I'm young, I have never been admitted, why do I need? I don't need any help.
Dr. Abdi, there's so much that still needs to be unpacked, even well before October, and it's our hope that you will come again as we continue to unpack and look at the benefits of this. Some of it makes sense, and of course, there's the fear that, okay, so will it run smoothly? And I think that needs to be continuous, and so we're looking forward to you having that conversation with you again. But we want to thank you so much for being here. Dr. Abdi Mohammed is the Director of the Social Health Authority. We've been having that conversation around the benefits of what SHA brings come October when it's all rolled out. Thank you very much. It's 1 minute after 9.
Thank you.
Ale umetenda Baba, yote ni makuu.